History of obstetrics. The term obstetrics originates from the Latin word obstetrix, which means midwife. Obstetrics is derived from the verb obster, which means to stand before, or to stand in front of, a reference to the midwife's role of standing before the woman during childbirth. Today, obstetrics is defined as the prevention, diagnosis, and management of pregnancy from approximately 20 weeks of gestation. Origins of obstetrics. The history of obstetrics cannot be separated from the history of midwifery. Throughout history, it has been observed that women were always accompanied by a female companion during the birthing stage. In ancient Greek mythology, goddesses were present at deliveries. In primitive tribes, it was the mother or a female relative, and even the Old Testament makes reference to midwives. Midwifery was traditionally the primary practice for managing childbirth. In ancient Greece, the Hippocratic texts described obstetric techniques, but destructive tools for managing obstructed labour were developed later in the Roman era. These tools were associated with a high risk of maternal mortality. Between CE 98 and 138, Soranus of Ephesus described antenatal care and methods for managing breech presentations. During the early medieval period in Europe, there was a decline in medical knowledge, with superstition and church doctrines influencing women's health. However, the Islamic Golden Age preserved and advanced obstetric knowledge, with scholars like Al-Razi and Avicenna contributing significantly to obstetrics. In contrast, the Renaissance period saw a resurgence of classical text and significant scientific advancements. The rise of obstetric texts and tensions. In 1513, Eucharius Russlin, an apothecary who transitioned to medicine, published the best-selling obstetric textbook, the Rosengarten. This book, which drew heavily on ancient works, including those of Soranus, also criticised midwives for their perceived ignorance and superstitions. This led to increasing tension between midwives and the emerging male practitioners, man midwives and instrumental delivery. In the 17th century, male midwives, known as accoucheurs, became increasingly prominent. François Morisot, one of the most well-known accoucheurs of the time, made significant contributions, including advocating for delivering babies in bed rather than on stools, and supporting the perineum during childbirth. The Morisot smelly veit manoeuvre for breech deliveries is named after him, although it was based on the uncredited work of Jacques Guillemot. In the late 1600s, the Chamberlain family developed the first obstetric forceps. Later in the 18th century, William Smellie refined the design of the forceps by introducing a pelvic curve and the English lock system, which allowed the blades to be inserted separately. Caesarean section and puerperal sepsis, late 1700s and late 1800s. In the late 1700s, Alexander Gordon identified a link between puerperal fever and erysipelas. In the early 1800s, Oliver Wendell Holmes recognised that doctors were often vectors of infection. The first documented caesarean sections with maternal survival were reported as follows. In the 1500s, Jacob Neuffer reportedly performed a successful caesarean section on his wife, who went on to have 5 more vaginal deliveries. However, the authenticity of this claim has been questioned. In 1738, Mary Donnelly performed a caesarean section in Ireland. In 1793, James Barlow performed a caesarean section in England. In 1821, James Miranda Barry, a woman disguised as a man, performed a caesarean section in South Africa. In 1827, John Richmond performed a caesarean section in America. All these procedures were performed without anaesthesia. In the 1840s, Ignaz Semmelweis demonstrated that hand-washing with chlorinated lime water dramatically reduced puerperal fever. In 1847, James Young Simpson introduced the use of chloroform during childbirth, making significant contributions to obstetric anaesthesia. By the 1880s, aseptic surgical techniques were introduced and the classical caesarean section became the standard approach. In 1906, the lower segment caesarean section was introduced, reducing the risk of uterine rupture. Expansion of obstetrics and modern challenges, early 1900s. In the early 1900s, obstetrics expanded beyond childbirth to include antenatal care. Antenatal clinics were established in Boston in 1911, Sydney in 1912, and Edinburgh in 1915. In 1916, Christian Kjelland designed rotational forceps to align the fetal head in malpositions such as occiput posterior or transverse. In the 1950s, Tage Malmström invented the modern vacuum extractor, which caused less maternal trauma than forceps, but was less reliable for achieving successful delivery. Despite advancements, maternal mortality remained high in Britain during this period. This was partly due to the rise of poor asepsis, unnecessary instrumental deliveries with chloroform, and the routine use of unregulated interventions, as it was believed that natural delivery without assistance was unsuitable for civilized women. Reducing maternal mortality, 1930s to 1950s. In 1935, the introduction of sulfonamides significantly reduced maternal mortality. Gerhard Domach was awarded the 1939 Nobel Prize for Medicine for this discovery. Other important interventions included the use of ergometrine and oxytocin to prevent postpartum hemorrhage, the introduction of safe blood transfusions, the reduction of bed rest after delivery to lower the risk of thromboembolism, and the removal of junior trainees from labour wards. Fetal health and modern obstetrics, 1960s and beyond. By the 1960s, attention shifted to improving fetal outcomes. The development of fetal ECG and fetal blood sampling, pioneered by Edward Hahn, Roberto Caldeiro Barcia, and Eric Salling, represented major advancements in monitoring fetal health. Obstetric ultrasound was developed by Ian Donald, an obstetrician, and Tom Brown, an engineer. Ian Donald, who graduated with a BA from the University of Cape Town and earned his medical degree from the University of London. Further advancements lead to the development of fetal medicine. Current global challenges. Despite significant improvements in maternal mortality rates in Europe, maternal mortality remains a major issue in the global south. The leading causes include sepsis, hemorrhage, hypertensive disorders, and unsafe abortions. These were the same leading causes of maternal mortality in the United Kingdom nearly a century ago. From history, you can appreciate key themes and challenges emerge, which include the role of women in obstetrics, with the evolution of midwifery and the increasing role of male physicians, the impact of technology on maternal and infant health, including ultrasound, fetal monitoring, and surgical techniques, global health disparities, especially in low-resource settings,